This is the description of an open inguinal orchidopexy and herniorrhaphy performed at the University of Florida. A 2 cm incision is made directly overlying the external inguinal ring along the lines of Langer. Dissection proceeds down to and through scarpus fascia. Small retractors can assist this dissection. Scarpus fascia can be identified as it rolls over top of the external oblique fascia. Scarpus fascia is opened, revealing the external oblique fascia. Identifying the lateral shelving border helps identify the external inguinal ring. The authors use Metzenbaum scissors oriented perpendicularly to the patient. Following the shelving border inferiorly toward the scrotum will lead the surgeon directly to the external inguinal ring. And manual retraction on the scrotum will help reveal the testis. The tunica vaginalis is grasped and gentle traction pulls it from the incision. The gubernaculum at the inferior pole of the testis is thinned and divided. The surgeon should be wary of avoiding injury to a long looping vas deferens in this location. Once the gubernaculum is released, the testis should be able to be pulled into the field with the spermatic cord remaining as the lone point of attachment. External spermatic fascia and cremasteric muscle fibers are circumferentially released from the spermatic cord. As the cremaster muscle forms a cloak around the spermatic cord from anterior to posterior, the posterior aspect of the spermatic cord commonly lacks well-defined cremasteric fibers and is an ideal place to begin the dissection. The fiber should be released to the level of the external inguinal ring. The internal spermatic fascia is a thin layer deep to the cremasteric muscle and superficial to the tunica vaginalis. This can be released using a similar technique to releasing the external spermatic fascia and cremasteric fascia. Care should be taken to visualize the patent processus vaginalis wrapping nearly completely around the spermatic cord with the vital cord structures located posteriorly. Once all tissue attachments surrounding the tunica vaginalis have been released and the vital cord structures identified, the tunica vaginalis can be opened anteriorly as it overlies the testis. Opening the tunica vaginalis in this location allows visualization of the testis for safe entry into the tunica vaginalis. Opening the tunica vaginalis is necessary to confirm a patent processus vaginalis or a communicating hernia sac. The hernia sac must be separated from the vital cord structures. In separating the hernia sac from the vital cord structures, the surgeon should bear in mind that the hernia sac wraps nearly completely around the spermatic cord and the vas deferens will generally be located in a posterior lateral position. The authors use hemostat clamps to maintain slight inferior traction on the testis and lateral traction on the hernia sac leaflets. A fine DeBakey forceps may be used to roll the vital cord structures off the posterior aspect of the hernia sac. With the hernia sac completely and circumferentially isolated, the stump is separated from the vital cord structures as proximally toward the external inguinal ring as possible. With the hernia sac dissected as proximal as possible, a right angle clamp can be placed on the hernia sac and excess hernia sac excised. Before high ligation of the hernia sac, the vital cord structures should be confirmed. Here you can see the vas deferens and vessels. Gentle manual pressure on the abdomen will confirm the entire hernia sac is secured. The hernia sac stump is then double ligated with polygalactin suture and released back into the abdomen. Again, abdominal wall pressure confirms the absence of residual hernia. The testis and the vital cord structures are now isolated as they emerge from the external inguinal ring. A blunt plane of dissection is developed with a fifth digit from the inguinal incision into the ipsilateral hemiscrotum. A 1 cm oblique incision is made in the scrotal rugae in the anterior midface of the ipsilateral hemiscrotum. Using a hemostat clamp, a predartos pocket is expanded in the potential space between the dependent hemiscrotal dermis and the surrounding dartos tissue. The testis is then brought from the inguinal incision through the plane of dissection over the pubic tubercle and into the ipsilateral hemiscrotum. The authors use a long clamp from the scrotal incision to pull the testis to the desired location. Once the testis is in the scrotum, it's imperative to check the orientation of the spermatic cord and the testis to be sure the spermatic cord has not been inadvertently twisted. The testis is secured into the dependent scrotal dermis within the developed predartos pocket with 2 sutures. The authors prefer non-absorbable suture placed between the medial and lateral scrotal dermis to the corresponding location at the inferior pole of the testis. The authors recommend throwing the scrotal stitch first, then checking the scrotum for satisfactory location and absence of incidental through and through buttonholing of the skin. At the testis, the suture should be placed through the reflection of the tunica vaginalis parietal and visceral layers. The sutures of the testis should run superficial through these layers and not deep to injure the tubules of the testis. Once the testis stitch is thrown, the surgeon should attempt to keep it, as removing the stitch risks uncontrolled bleeding. If there is anticipated tension on the orchidopexy, the surgeon may run an additional transscrotal suture from the dependent aspect of the ipsilateral hemiscrotum to the inferior aspect of the testis, then back out through the scrotum. An absorbable suture may be used. Alternatively, a permanent suture may be secured through a sterile button for removal later in the clinic. Here you can see the 3 orchidopexy sutures, a medial and lateral non-absorbable suture, and an inferior absorbable suture. With the testis secured in a satisfactory location, the wounds may be irrigated and hemostasis ensured before the wound closure is performed in a typical fashion. Again, the authors recommend confirming proper orientation of the spermatic cord and testis prior to final wound closure.